Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient who comes in with rapidly progressive leg weakness, numbness rising up from the feet, and new urinary retention. The key question is whether this is a spinal cord problem, a peripheral nerve problem, or a compressive emergency. When the symptoms are bilateral, there is a sensory level, and the bladder is involved, you should immediately think about myelopathy. Transverse myelitis means inflammatory dysfunction of the spinal cord, causing motor, sensory, and autonomic deficits below a spinal level. The word transverse does not necessarily mean the whole cord is completely destroyed. It means the inflammatory process affects spinal cord function across motor, sensory, and autonomic pathways, producing a clinical picture below the level of the lesion. To understand transverse myelitis, think in 4 boxes: mechanism, causes, clinical features, and urgent management. First, the mechanism. Immune-mediated inflammation develops within the spinal cord. This causes demyelination, axonal injury, or both. Once the cord is inflamed, the ascending sensory pathways, descending motor pathways, and autonomic pathways cannot conduct normally. That is why the patient develops sensory symptoms, weakness, and bladder or bowel dysfunction together. The motor pathway involvement affects the corticospinal tracts. This usually causes upper motor neuron weakness below the lesion. However, there is an important early trap. In the acute phase, spinal shock can cause flaccid weakness and reduced reflexes. Later, as spinal shock resolves, spasticity, brisk reflexes, and extensor plantar responses may emerge. So early areflexia does not always mean this is a peripheral neuropathy. The sensory pathway involvement affects the spinothalamic tracts and dorsal columns. Spinothalamic involvement causes impaired pain and temperature sensation. Dorsal column involvement causes loss of vibration and proprioception. Clinically, the key clue is a sensory level, because a clear level on the trunk or limbs localizes the problem to the spinal cord. Autonomic pathway involvement explains the bladder, bowel, and sexual dysfunction. Urinary retention is especially important. In an exam vignette, bilateral weakness plus a sensory level plus urinary retention should make you treat this as a spinal cord emergency until proven otherwise. Now let us group the causes. One broad group is post-infectious or post-vaccine immune activation. Here, the immune system is activated by a preceding trigger, and molecular mimicry can lead to inflammation within the cord. Another group is demyelinating disease. Multiple sclerosis can cause transverse myelitis, typically with shorter partial cord lesions, often involving the peripheral cord. Neuromyelitis optica spectrum disorder associated with AQP4 antibodies is different. It is an astrocytopathy and can cause severe necrotizing longitudinally extensive cord lesions. MOG antibody disease can also cause inflammatory demyelination and may involve the conus. A further group is systemic autoimmune disease. Think of systemic lupus erythematosus, Sjogren's syndrome, sarcoidosis, and Behçet's disease. These are important because the spinal cord presentation may be part of a wider inflammatory disorder. And finally, do not forget infective mimics or infective causes. These include herpes simplex virus, varicella zoster virus, HIV, syphilis, tuberculosis, and Lyme disease. The exam trap is to call everything autoimmune before considering infection, compression, infarction, and metabolic causes. Clinically, transverse myelitis usually evolves over hours to days. This time course helps distinguish it from a sudden spinal cord infarct, which is usually abrupt, and from many compressive or degenerative causes, which may be more gradual, although compression can also present acutely. Patients may have weakness below the lesion. A thoracic cord lesion commonly produces paraparesis. A high cervical lesion is more dangerous because it can affect respiratory function. So in a patient with cervical myelitis, always think about breathing, cough strength, and ventilatory compromise. Pain, paresthesia, altered sensation, and a sensory level are common. Bladder involvement is not a minor symptom. It is a major localizing clue and a major management issue. Urinary retention may need urgent catheterization, and immobility creates risks of venous thromboembolism and pressure injury. Now, diagnosis. The first urgent investigation is MRI of the whole spine with gadolinium. This has 2 jobs. It confirms cord inflammation, and just as importantly, it excludes compression. You must not miss compressive myelopathy, epidural abscess, malignancy, or another surgical cause. Brain MRI is also useful because it may show patterns suggesting multiple sclerosis, neuromyelitis optica spectrum disorder, or MOG antibody disease. The spinal cord lesion pattern also helps. Shorter partial lesions suggest multiple sclerosis. Longitudinally extensive lesions should raise concern for NMOSD, MOG, sarcoidosis, infection, or other inflammatory causes. CSF may show pleocytosis and raise protein, supporting inflammation. Oligoclonal bands may suggest multiple sclerosis, but they are not specific on their own. Always interpret CSF with the clinical picture, MRI pattern, and antibody testing. Blood tests should be directed at the likely causes and mimics. AQP4 IgG is important for neuromyelitis optica spectrum disorder. MOG-IgG is important for MOG antibody disease. Autoimmune screening, inflammatory markers, B12 and copper levels, and infection testing should be considered according to the presentation. MRCP trap, before calling it transverse myelitis, always exclude mimics. The dangerous mimics include compressive myelopathy, spinal cord infarction, epidural abscess, malignancy, B12 deficiency, and copper deficiency. Missing compression or infection can cause devastating harm. Treatment is urgent. High-dose intravenous methylprednisolone is first line because it suppresses inflammatory demyelination and cord edema. Reduced inflammation can improve conduction through demyelinated pathways and may limit further injury. If the presentation is severe, or if there is poor response to steroids, plasma exchange is considered. This is especially important in antibody-mediated disease such as neuromyelitis optica spectrum disorder and MOG antibody disease. The principle is simple. Plasma exchange removes pathogenic antibodies and complement from the circulation. Supportive care is not optional. Catheterize if there is urinary retention. Give venous thromboembolism prophylaxis if immobile. Protect the skin from pressure injury. Start physiotherapy and rehabilitation early. Treat neuropathic pain, manage bowel function, and monitor respiratory function if the lesion is high cervical. Long-term treatment depends on the cause. Multiple sclerosis, NMOSD, and MOGAD have different relapse prevention strategies, so identifying the underlying diagnosis matters. In particular, NMOSD needs careful long-term immunotherapy because relapses can be severe and disabling. If you remember one thing, remember this. Transverse myelitis is an inflammatory spinal cord syndrome causing bilateral motor, sensory, and autonomic dysfunction below a level, and the urgent priority is MRI whole spine with gadolinium to confirm inflammation and exclude compression. Quick recall. A patient develops bilateral leg weakness over 2 days, a sensory level at the umbilicus, and urinary retention. Early reflexes are reduced, but plantar responses later become extensor. Why can the early examination be misleading? The answer is acute spinal shock can initially cause flaccidity and areflexia before the expected upper motor neuron signs of corticospinal tract involvement emerge. A patient with severe longitudinally extensive transverse myelitis does not improve after high-dose intravenous methylprednisolone, and AQP4 IgG is positive. What treatment should be considered next, and what is the mechanism? The answer is plasma exchange, because it removes pathogenic antibodies and complement, which is especially important in antibody-mediated disease such as neuromyelitis optica spectrum disorder. Do subscribe to the channel for further videos.